Hello and welcome everyone. In today's video, we're focusing on a topic that sits at the intersection of cardiology and neurology, often shrouded in mystery: syncope. One of the most critical tools in our diagnostic arsenal for syncope is the electrocardiogram. In this video, we have 3 intriguing cases lined up, each presenting a unique ECG tracing from patients with unexplained syncope. Together, we will analyze these tracings, learn how to interpret them, and potentially unravel the underlying causes behind these syncope episodes. The first electrocardiogram we're examining is from a 21-year-old patient with an unexplained syncope history, normal electrolyte levels, and no medication use. I recommend pausing the video at this point to take your time to analyze the ECG before we delve into the discussion. Upon examining the tracing, we can see a sinus rhythm with normal atrioventricular conduction. The QRS complexes and their angles appear normal. However, our attention is drawn towards ventricular repolarization, where we can clearly observe a significant prolongation of the QT interval. A quick tip when you're examining an ECG to determine whether the QT interval is prolonged or not, particularly for heart rates around 60 beats per minute, is to look at the distance between two QRS complexes. Divide this interval in half. If the T wave extends beyond the midpoint between these two QRS complexes, it's highly suggestive that the QT interval is prolonged. Of course, we can only confirm this through actual calculation. Remember, the QT interval starts from the beginning of the QRS complex and goes up until the end of the T wave. And it's crucial to adjust this for heart rate. That is, we take the QT interval in seconds and divide it by the square root of the RR interval, also in seconds. So in this case, we likely have a patient with long QT syndrome. Given the absence of any associated factors, it could even be a case of congenital long QT syndrome, since she doesn't use any medication or have electrolyte imbalance to justify acquired long QT syndrome. Her syncopal episodes might be due to recurring polymorphic ventricular tachycardias, a common feature of this syndrome. The second electrocardiogram is from a 37-year-old patient with a history of syncope. Upon analyzing this electrocardiogram, we notice that the QRS complexes are irregular and exhibit diverse morphologies. Initially, it is not possible to visualize the P wave. If we scrutinize the trace, it's evident that at times we have extremely broad QRS complexes, occasionally somewhat broadened, and at other times almost normal QRS complexes. They alternate in this rhythm. In fact, this electrocardiogram is of a patient with ventricular pre-excitation syndrome, meaning he has an accessory atrioventricular pathway and has developed atrial fibrillation. Hence, sometimes the impulse generated in the atria is conducted by the standard conduction system, and we observe normal narrow QRS complexes. At other times, this impulse is exclusively conducted by the accessory pathway, and we see an extremely broadened QRS complex. Occasionally, there's mixed conduction between the accessory pathway and the atrioventricular node, resulting in slightly broadened QRS complexes. The rhythm is consistent with atrial fibrillation due to its irregularity. Patients with ventricular pre-excitation syndrome often have a higher predisposition to develop atrial fibrillation. Most times, treating the accessory pathway and managing the WPW syndrome with ablation can almost entirely eliminate the atrial fibrillation. These patients, when they develop atrial fibrillation, tend to reach very high ventricular rates because even though the atrioventricular node is holding back the atrial stimulus, this stimulus ends up passing through the accessory pathway, leading to a rapid ventricular response. Consequently, this can often cause syncope, hemodynamic instability, and if not treated, it could progress to ventricular fibrillation and result in death. The last electrocardiogram is from a 75-year-old patient with a history of syncope. Upon initial examination of the electrocardiogram, we can readily observe that the atrial rate is different from the ventricular rate. If we measure the PP intervals, which indicate the atrial frequency, we notice that some P waves fall into the T waves, rendering them invisible. Additionally, there is a clear 3:1 relationship between the P waves and the QRS complexes. In other words, for every 3 atrial complexes, we're seeing 1 ventricular complex. So we're dealing with a 3:1 atrioventricular block. Along with this, there is an interventricular conduction disorder with a pattern of right bundle branch block, accompanied by an extreme leftward shift of the axis with positive D1, negative AVF, and negative D2. We are therefore witnessing an axis deviation indicative of a left anterior fascicular block. In summary, this patient has a 3:1 AV block, a right bundle branch block, and a left anterior fascicular block. Consequently, this patient likely has a severe bradyarrhythmia, causing syncope due to a significant disorder in atrioventricular conduction, and a permanent dual-chamber pacemaker should be implanted. Thank you for taking the time to learn with us today. Please share this video with your colleagues, subscribe to our channel, and give us a positive evaluation. We hope to see you soon in our next video.